In this brief video, I'm going to show you give a demonstration of the Bullard laryngoscope and all the pieces and parts. There are a lot of pieces and parts, and we're going to walk through each of those. The first is the main laryngoscope. It's a rigid laryngoscope with a very highly curved blade. One of the great aspects of this particular device is how narrow it is. Instead of the 15 millimeters we need with modern laryngoscopes, you can see it's only about 1 millimeter in thickness at its thickest point. A handle to hold on to and give it a little bit of a lift, and I'll show you the right trajectory. Multiple attachment ports. This main one is for a standard laryngoscope handle as the light source. You can see that little attachment there that should look very familiar to you. The other nice thing is it has an optical, the lens is adjustable to focus if needed. So the laryngoscope, standard handle, the blade extender, and a little tool to remove that blade extender, a standard stylet, and then it comes with a multifunctional. Use one or the other. The blade extender is used for most patients, and it clicks on, you can see right to the end of that, and then needs a tool so that this little blade extender does not come off and stay in the patient. It attaches securely, but then you do need a little blade remover tool to get that off. So let's look at the standard stylet. You could use this for pretty much any adult situation. It comes, you can see it's a nice thin wire. There's an attachment point, clicks right into this most posterior point there, and you have to squeeze it to click it down in place, and then just make sure that it's appropriately attached and isn't going to come off. It does need lubrication, and you see it follows the exact contour of the blade itself. You need to lubricate that stylet, and that's what you're going to load your tube up and onto. Oil-based lubricants worked best for these standard stylets versus your water-based lubricant. So feed that all the way up and onto that stylet, and unlike other types of laryngoscopes, we actually can feed that until the tube is all the way up with the stylet still sticking out some. It must sit in exactly that side channel, and you squeeze them together so it stays there, and then attach your standard laryngoscope handle as the light source. There's a port adapter here with a lure adapter tip. You can use that for oxygen or to put local anesthetic into the patient as you spray as you go. We're just going to attach that here. Make sure one last time that the stylet is in the appropriate channel and that the light is working nice and bright. And you sort of hold it in that spot and then squeeze it together there so it stays. And then all that one big piece. Ideally, you don't have to manipulate the patient's mouth at all. You're not aligning axes. You can adjust the focus if needed. Using a straight up trajectory, get a good view. If you don't get a good view in the first attempt, you can do this maneuver and then reposition the blade tip. And then you're going to hold that view. Optimal view is where the stylet's pointing right around 5 o'clock. And that'll allow you to slide that tube. It'll project it right off and out into the center of the vocal cords. Hold the tube securely, rock the entire device forward as you remove the stylet from the endotracheal tube and leave that in place. That part can be a little bit tricky, but you can see you don't really have to manipulate the head and neck or open the mouth significantly. The multifunctional stylet gives you a little bit more oomph to it. It's a little bit thicker. You can see it attaches differently. It's still going to sit alongside that blade, but it has to attach to the outside of the optical port there. So you just line it up where you want it to be, and then use the little screw adapter to tighten that up in exactly the correct spot. Again, you can see where the stylet kind of contours the side of the blade. It also needs oil-based lubricant. And then again, you can see it's a little thicker. It's got some more substance to it, which is one of the reasons why it works a little bit better. It doesn't flop it around quite as much. Slide the tube carefully up and on. You do have to use a good sized tube. This is a 7/0 endotracheal tube. It's nice and snug. The bigger tube you can use, the better. And again, you can have that stylet sticking out the end of that, because that's what you're going to see when you're looking through the viewer So you want to see that stylet so you can line that up with that 5 o'clock position when you use it. Again, you use a standard laryngoscope handle. And this is the great thing. That multifunctional adapter is a hollow adapter, and it will accommodate a Cook catheter or other intubation obturator. Again, we're going to line it up, make sure the view is what we want it to be. We're going to squeeze that tightly so that the stylet stays in exactly the correct position and is secure. The tube can be up such that the stylet's sticking out from the end of it. You don't have to have the tube protected by the stylet. I'm going to have my Cook catheter ready. I'm going to go ahead and take off that rapid fit adapter so if I need it, it's going to slide easily through the multifunctional stylet. There we go. So I'm going to try to optimize that view. Look straight up if need be if the view is not perfect. Then I'm going to go ahead and slide that tube off. Not quite going. Hanging up a little bit there. So I'm going to try plan B. Always have a plan B, and I already had that ready. I'm going to grab the Cook catheter. I'm going to put that down through the multifunctional stylet, and I'm going to go ahead and look and watch as that Cook catheter comes out the end of the multifunctional stylet. Once I get that fed all the way down and out through the vocal cords, and you'll notice in just a moment here, once that's out there, I'm going to move my hand down to advance the tube off of the multifunctional stylet at this point. So I put the catheter out, sort of like a bougie, as an obturator. Now I'm going to remove, rocking the entire thing forward, hold the tube. I can leave that Cook catheter in place if I like, just in case the tube was not quite through the vocal cords. I can advance it just a little bit to be sure that it's past the vocal cords, and then advance the endotracheal tube off of that and remove the Cook catheter. And then, of course, you check tube placement just as you would for any other intubation. A couple of questions to think about now that you've seen this Bullard laryngoscope that I've talked about so much in NRSA 603.